Welcome to our specialized session on GI cancer, really designed for you, the radiation oncology resident. Today, we're doing an in-depth exploration of a topic that's still a pretty big global health challenge: the tricky and evolving management of resectable gastric cancer. It's often caught late, unfortunately, which makes effective multidisciplinary treatment just absolutely crucial. And the approach, well, it's been a fascinating journey over the decades, constantly balancing, aggressive surgery with smarter, more effective systemic therapies. And that's the path we're going to trace today.
That's exactly right. And this isn't just an academic exercise. What we're covering today is really fundamental for your day-to-day clinical work. Gastric cancer management is, well, it's complex. The standards keep changing based on these big clinical trials. So our goal today is to walk you through it step by step, from those first crucial distinctions you need to make through the key surgical principles, and then hitting the landmark trials that really shaped perioperative care. And we'll sprinkle in some practical decision-making tips, clinical pearls, and some board-style questions to help lock it all in.
Okay, sounds like a plan. So let's start right at the beginning. The first, and you could argue the most critical step. Before any treatment talk, getting the classification right is vital, especially for tumors near that tricky spot, the gastroesophageal junction, the GE junction. It really feels like the first major decision point, doesn't it? So what's the actual rule? How do we figure out where to start, and why is it so incredibly important for us as radiation oncologists?
That's a great way to put it, a major decision point, because it absolutely dictates everything else that follows. Staging, treatment choice, even how we think about radiation fields. The American Joint Committee on Cancer, the AJCC 8th edition, gives us a really clear rule. It all comes down to one thing.
Mm.
Where is the tumor's epicenter located? Think of it like this. Okay, you're standing at a crossroads. The path you pick right there determines the whole rest of your journey, the map you use, the terrain you cover. For GE junction tumors, that crossroads is defined by one simple measurement. Is the tumor center, its epicenter, more or less than 2 centimeters into the proximal stomach?
Okay, so 2 centimeters is the magic number.
Exactly, 2 centimeters. So scenario 1, if the tumor's epicenter is within those first 2 centimeters of the proximal stomach, meaning it's mostly in the esophagus and just peeking into the stomach, or maybe centered right at the cardia, then it's staged and treated as an esophageal cancer. No question. This covers what we call SEERT type 1 and SEERT type 2 tumors. Type 1 is usually distal esophagus adenocarcinoma, often from Barrett's. Type 2 is a true cardia tumor, right at the junction. And the implication for us, huge. The whole workup, the surgery, maybe a transhiatal esophagectomy, and definitely the systemic and radiation plans follow esophageal cancer guidelines, like using the cross protocol for neoadjuvant chemoradiation. That becomes a standard option.
Got it. Esophageal rules apply if it's within 2 centimeters. So what about the other side of that crossroads?
Right. So scenario 2, if the epicenter is located more than 2 centimeters down into the proximal stomach, then it's definitively staged and managed as a gastric cancer. And this is true even if the tumor itself grows back up and invades the GE junction. That doesn't change the classification if the epicenter is clearly gastric. This is typically what we call a SEERT type 3 tumor. And that distinction, that simple 2 centimeter threshold, it might seem small, but as I said, it changes everything. Your staging scans, like CT and PET, focus on different nodal basins. The surgical approach is different. And crucially for us, the systemic therapy sequence and the potential role and fields for radiation therapy are completely different. An esophageal might get definitive chemoradiation, right? A gastric primary, much more likely perioperative chemo like FLOT. Getting this first step correct is just non-negotiable. It sets the stage for the entire multidisciplinary team.
That crossroads analogy really works. It makes it crystal clear why that initial anatomical call is so fundamental, affecting literally everything we do next, especially for radiation planning.
Okay, so once we've figured out where it is anatomically, we need to zoom in, right, down to the microscope level. Moving from location to the cells themselves, what are the main histological types of gastric cancer we see? And do those types behave differently? Do they affect prognosis or how they spread?
Yeah, absolutely. Histology adds another critical layer. The overwhelming majority, like 90% plus, are adenocarcinomas. But within adenocarcinoma, we generally split them into two main types. And yes, they have very different characteristics, different prognoses, and kind of different patterns of spread. Really important to know the difference.
Okay, what are they? The first is the intestinal type. Like the name suggests, these tumors tend to form glands, structures that look a bit like intestinal lining under the microscope. Epidemiologically, you see these more often in high-incidence areas, think parts of Asia, Eastern Europe, South America. And their development is often linked to chronic environmental stuff. The big one is chronic infection with Helicobacter pylori, H. pylori, That infection leads to chronic inflammation, stomach lining atrophy, changes called intestinal metaplasia, basically creating the conditions for this type of cancer to develop over time. Clinically, they often form more distinct masses, which, might make them slightly easier to resect completely, though they can certainly still metastasize.
Okay, intestinal type gland forming, H. pylori link, high incidence areas. What's the other one?
The second type is the diffuse type, and this one is quite different, microscopically and clinically, often more aggressive, unfortunately. These tumors are made of poorly cohesive cells. They don't stick together well, they don't form nice glands. Instead, the cancer cells tend to infiltrate, to spread out individually or in little clusters through the stomach wall, almost like soaking into blotting paper rather than forming a lump. This makes the tumor margins really hard to define, both for the surgeon and the pathologist. And the classic microscopic look, you'll hear this term a lot, is the signet ring cell. There's a big blob of mucin inside the cell that pushes the nucleus off to the side so it looks like a ring with a stone.
Ah, the signet ring cells. I've heard of those.
Exactly. Highly characteristic. And clinically, this diffuse type generally means a worse prognosis. Part of that is its aggressive biology, but it also has a higher tendency for distant spread, especially peritoneal spread. The cells just seem to easily shed into the abdominal cavity and seed the peritoneum, leading to carcinomatosis. Because it infiltrates so diffusely, getting a true R0 resection can be harder, and there's just a higher risk of microscopic disease being left behind or spreading, even if the surgery looks successful locally. This biology really underscores why systemic therapy is so absolutely vital for these patients. Local treatment alone often just isn't enough.
Wow. Yeah, that's a really stark contrast, especially that tendency for peritoneal spread with the diffuse type. That sounds particularly challenging. Okay, so to help us keep those straight, intestinal versus diffuse, do you have maybe a quick mnemonic we can use, something easy to remember those key differences?
Yeah, absolutely. A simple way to keep the key features straight is to use the mnemonic ID the enemy. Helps you quickly recall intestinal and diffuse types.
Okay, ID the enemy. I like it. How does it break down?
So the I is for intestinal type. Think intestinal interconnected cells forming glands, intestinal linked to H. pylori infection,
Sure.
intestinal common in high incidence areas.
Okay, for interconnected glands, infection, high incidence areas. Got it.
And then the D is for diffuse type. Think diffuse, dispersed cells, poorly cohesive, infiltrating. Diffuse, signet ring cells, a distinctive feature. Diffuse equals worse prognosis, propensity for distant, especially peritoneal spread.
D for dispersed cells, distinctive signet rings, distant spread. Perfect. ID the enemy. That's actually really helpful, thanks. Okay, so we've classified it anatomically. We understand the histology. Let's move to treatment, starting with the foundation for cure. Surgery. Surgery is really seen as the cornerstone for resectable disease, the main shot at cure. What are the absolute main goals when the surgeon goes in? And how does lymph node dissection fit into that picture?
You're right. For potentially curable gastric cancer, surgery is the only modality that offers a real chance of cure. And when we talk about surgery, there are two absolute primary goals, non-negotiable if you're aiming for cure. First, you need a complete R0 resection. We mentioned this before, but it means getting the entire tumor out with microscopically clean margins. No cancer cells left at the edge of what was removed. This is absolutely critical for local control, stopping the cancer from growing back right there, and for long-term survival. An R1 or R2 resection, where microscopic or gross disease is left behind, dramatically increases recurrence risk.
R0. Got it. What's the second goal?
The second crucial goal is an adequate lymph node dissection. And the adequate part, well, that was debated for a long, long time, especially between surgeons in the East, like Japan and Korea, and surgeons in the West. Historically, this led to two main defined levels of dissection.
Okay, what were those levels?
You have the D1 dissection. This is the more limited approach. It means taking out only the perigastric lymph nodes, the ones right next to the stomach, along the lesser and greater curves.
Yeah.
Basically, the nodes immediately draining the stomach.
Right, just the closest ones.
Exactly. Then you have the D2 dissection. This is a much more extensive operation. It includes all the D1 nodes, plus nodes that are further out along the main arteries that branch off the celiac axis. So nodes along the left gastric artery, the common hepatic artery, and the splenic artery. As you can imagine, this involves dissecting around major blood vessels, sometimes near the pancreas and spleen. It's technically much more demanding. But these D2 nodes are key stations for regional spread.
Okay, D2 sounds way more thorough, hitting more potential spots where cancer could have spread. So why was there even a debate? Why would Western surgeons lean towards the less extensive D1 if D2 seems oncologically better? It feels like that classic tension, more aggressive treatment versus immediate risks.
That's exactly what it was. It boiled down to morbidity and mortality. Western surgeons historically were very concerned about the higher rates of complications and deaths seen with D2 dissections. Especially back then, surgical techniques maybe weren't as refined, post-op care wasn't as advanced. Things like managing pancreatic leaks or splenic injuries were tougher. The D2 dissection, because it gets closer to the pancreas and spleen, just inherently carried higher risks for those specific complications. So the thinking was, look, D1 seems reasonably effective, and it's much safer up front. Why put patients through the higher risk of D2?
Makes sense from a safety perspective initially. So how did that change? What settled the debate? Was it just better surgical technique over time, or was there specific trial data?
It was really definitive trial data from long-term follow-up. Technique improvement definitely helped make D2 safer over time, but the evidence came from two big European randomized trials, the Dutch D1-D2 trial and a British MRC trial. Now, initially, both trials actually confirmed the surgeon's fears. They did show higher rates of post-operative complications and higher early mortality with D2 compared to D1.
Ah, so the initial results supported D1.
In terms of immediate safety, yes. But then came the crucial long-term follow-up data, especially from the Dutch trial. And what that showed, years down the line, was that despite the higher upfront risks, the D2 dissection led to significantly lower rates of local regional recurrence, less cancer coming back in the surgical bed or nearby nodes. And, most importantly, it resulted in significantly better cancer-specific survival. That was the game changer. It proved that the oncologic benefit, the long-term cure rate, was superior with D2, outweighing the initial morbidity if, and this is key, if the surgery is done well by experienced teams. That long-term data completely shifted the standard of care globally, and complication rates for D2 have dropped dramatically now with better training in high-volume centers.
That's a really powerful illustration of why long-term follow-up in trials is so vital. Initial safety concerns can sometimes be overridden by later survival benefits. So, based on that solid evidence, what are the official recommendations now for lymph node dissection? And are there any sort of strings attached or specific requirements we need to know about, especially when we're thinking about radiation planning later?
Okay, so based on that evidence, the National Comprehensive Cancer Network, the NCCN, guidelines are very clear. A D2 lymphadenectomy is recommended for all potentially curative gastrectomies. It's the standard. For us as radiation oncologists, knowing a proper D2 was done is really helpful. It means the key regional nodal basins should have been surgically cleared, which helps us define our target volumes if adjuvant radiation is needed later. It allows for more precise targeting.
Right, better surgical clearance means potentially smaller, more focused radiation fields if needed.
Exactly. But there's a really critical caveat. The NCCN strongly emphasizes that this D2 dissection should ideally be performed only at high-volume centers by experienced surgeons. Why? To minimize that morbidity we talked about. The complication rates are much lower when done by teams who do this frequently and have the infrastructure to manage potential issues. This is important for you to know when reviewing consults. Was the surgery done at a high-volume center? It impacts prognosis and potential delays before starting adjuvant therapy if the patient has a rough post-op course.
That's a really practical point. And what about the pathology report itself? Is there a minimum number of nodes they need to find?
Yes, absolutely. For accurate pathologic staging to really know the end stage, the pathologist needs an adequate sample. The standard is that a minimum of 15 lymph nodes must be recovered and examined from the specimen. If the report says fewer than 15 nodes were found, it kind of raises a red flag. Was the dissection maybe not quite a full D2? Or did the pathologist just not find them all? This matters because understaging the nodes could lead to undertreatment if someone misses out on necessary adjuvant therapy. So 15 nodes is that quality benchmark.
15 nodes minimum. Got it. That's crucial for staging in our adjuvant decisions. Okay, so we have optimal surgery now, a D2 dissection at a high-volume center. But even with that, recurrence rates for locally advanced gastric cancer were still too high, which obviously led people to think, we need something more, we need systemic treatment. Oh, yeah. And that brings us to a really pivotal study, the MAGIC trial. Can you tell us about MAGIC? What did it show, and why was it such a big deal at the time?
Yeah, the MAGIC trial, published back in 2006, was truly landmark. It essentially established the role of perioperative chemotherapy chemo before and after surgery for resectable gastric cancer. Before MAGIC, it was mostly surgery alone, maybe some adjuvant chemoradiation based on older U.S. trials, but there wasn't a clear standard for giving chemo around surgery to hit those micrometastases.
Right. People weren't sure if it was worth delaying surgery or if patients could tolerate chemo after a big operation.
Exactly. So MAGIC took 503 patients with resectable gastric, GE junction, or lower esophageal adenocarcinoma. They randomized them to either surgery alone, the standard then, or surgery sandwiched between chemo cycles. The chemo arm got 3 cycles before surgery, neoadjuvant, and then 3 cycles after surgery, adjuvant. The chemo regimen used was called ECF. That stands for EPE, Rubicin, Cisplatin, and continuous infusion
So it's EF. Okay. And what were the results?
The results were unequivocally positive, practice-changing, really. Compared to surgery alone, the perioperative chemo group had smaller tumors, more downstaging before surgery. They also had a higher rate of achieving that critical R0 resection. But the headline finding was survival. It significantly improved overall survival. The 5-year overall survival went from just 23% with surgery alone up to 36% with a perioperative ECF.
Wow. Okay, from 23 to 36%, that's a 13% absolute improvement. That's huge.
It was huge. It provided clear, level 1 evidence that adding systemic therapy around surgery was the better approach. ECF became the new standard of care overnight based on MAGIC.
A clear win for perioperative chemo. But I recall hearing that MAGIC also uncovered a pretty significant challenge, something that kind of tempered the enthusiasm a bit. What was that issue?
You're right. While the benefit was clear, MAGIC also highlighted a major practical problem: poor compliance with the full treatment plan. It turned out that only 42% of the patients assigned to the chemotherapy arm actually managed to complete all 6 cycles, 3 before and 3 after surgery.
Only 42%, less than half. Why was the completion rate so low?
2 main reasons. First, the toxicity of the ECF regimen itself. It wasn't easy chemo. Significant nausea, vomiting, fatigue, myelosuppression. Some patients just couldn't tolerate it. Second, and probably the bigger factor, was the difficulty of getting the adjuvant cycles in after major surgery. Patients are often recovering, maybe dealing with complications, weight loss, trouble eating. Trying to start fairly toxic chemo right after that was really tough. Many patients were too unwell, had surgical delays, or just refused further treatment.
Yeah, I can imagine. Recovering from a gastrectomy is hard enough without adding ECF on top.
Exactly. So this poor compliance really underscored how difficult delivering adjuvant therapy can be in this setting. And it immediately spurred the search for better regimens, ones that were hopefully more effective, but also better tolerated or easier to deliver so more patients could actually complete the intended therapy. That set the stage for the next big trial.
Which brings us to the current standard, right? The FLOT4 trial. Can you walk us through that one? How did it compare to MAGIC's ECF, and what did it find that made FLOT the go-to regimen now?
Precisely. The FLOT4 trial, a German study published in The Lancet in 2019, directly addressed the need for a potentially better perioperative regimen. And its results are why FLOT is now the undisputed global standard. FLOT4 was a head-to-head comparison. It took the established ECF regimen from MAGIC and went up against this newer triplet regimen called FLOT. The name FLOT comes from its components: fluor or your sil, leuco-4 in oxaliplatin, and a taxane, specifically taxon ER, which is docetaxel. So key differences are swapping cisplatin for oxaliplatin and adding docetaxel.
Okay, so 5-FU, leucovorin, oxaliplatin, docetaxel. Got it. What was the trial design?
They randomized 716 patients with resectable gastric or GE junction adenocarcinoma. Similar population to MAGIC. Patients got either ECF or FLOT perioperatively. Specifically for FLOT, it was 4 cycles before surgery and 4 cycles after.
And the results? Was FLOT better?
Oh yeah. The results were striking. FLOT was the clear winner across basically every important endpoint. Let's talk survival first. The median overall survival with FLOT was 50 months. Compare that to ECF, which was 35 months.
50 versus 35, that's a 15-month difference in median survival.
15 months. Remarkable. That's a huge improvement in a tough disease. Looking at 5-year overall survival rates, it was 45% with FLOT versus 36% with ECF. Again, a clear advantage. And it wasn't just survival. FLOT was also much better at shrinking the tumor before surgery. The pathologic complete response rate, the PCR rate, meaning no viable cancer found in the surgical specimen, was more than doubled with FLOT. It was 16% compared to only 6% with ECF.
16 versus 6% PCR, that's a big difference too. Better local response. What about side effects? Was FLOT much harder to tolerate?
Interestingly, the overall rates of serious adverse events were actually pretty similar between the two arms. So despite being more effective, it wasn't necessarily grossly more toxic overall. However, the types of side effects were different. ECF, as we knew, caused more nausea and vomiting. FLOT tended to cause more neutropenia, low white blood cell counts, needing careful monitoring, maybe growth factor support like GCSF. And it caused more neuropathy, nerve damage, tingling, numbness, especially from the oxaliplatin. That neuropathy can sometimes be long-lasting, which impacts quality of life. So different side effect profile, but manageable, and the efficacy benefit was just so substantial.
Right. So similar overall toxicity burden, just different types of issues to manage.
Exactly. And given that massive 15-month median survival advantage, FLOT4 definitively established FLOT as the new superior standard of care for perioperative chemotherapy in this setting. It's the benchmark now.
Incredible progress. That 15-month gain is really something. Okay, let's pivot to putting all this together for clinical practice. Let's talk clinical decision-making. For our residents listening, how do we synthesize this? When you see that new patient with potentially resectable gastric cancer, what's the step-by-step thought process? Can we walk through those key decision points or branch points again?
Absolutely. This is where rubber meets the road. Let's build that mental algorithm. First branch point, always, always, always. Is it gastric or esophageal? You have to apply that SIRT classification and the AJCC 2-centimeter rule for GE junction tumors. Is the epicenter within 2 centimeters treat esophageal or beyond 2 centimeters treat as gastric? Get this wrong. And the whole plan is flawed from the start. Staging, surgery, chemo, radiation, everything hinges on this.
Okay, step one. Classify GE junction based on epicenter location. Check. What's next?
Second branch point. What's the surgical plan? Assuming curative intent, the standard is gastrectomy with a D2 lymphadenectomy. You need to confirm this is the plan, and ideally, that it's happening in a high-volume center. And remember that pathology requirement, at least 15 nodes need to be examined for proper staging. This informs our understanding of the surgical clearance and subsequent adjuvant therapy needs. Right. Step 2. Ensure D2 dissection planned at a high-volume center, aiming for R0 and 15 nodes. Got it. Third branch point. What's the perioperative systemic therapy? For a medically fit patient, the Category 1 recommendation, based on FLOT4, is perioperative FLOT. 4 cycles before, 4 cycles after surgery. This is your go-to standard systemic regimen.
Okay, step 3, perioperative FLOT for medically fit patients. Seems straightforward for clear gastric cancers. But what about those tricky GE junction tumors again? You mentioned another trial earlier, POET.
Yes, excellent point. This is a crucial nuance, especially for us in radiation oncology, concerning GE junction tumors specifically. While perioperative FLOT is definitely a standard option for them too, you absolutely have to be aware of the German POET trial. POET looks specifically at locally advanced T3-4 GE junction adenocarcinomas. It compared neoadjuvant chemotherapy alone, using a regimen called PFL, versus neoadjuvant chemoradiation.
Ah, so comparing chemo alone versus chemo plus radiation before surgery for these junctional tumors, what did POET find?
POET found something very interesting for us. Adding radiation, even just 30 gray, which isn't a super high dose, significantly improved the pathologic complete response rate. The PCR rate jumped from about 2% with chemo alone up to 15% with chemoradiation. Now, the trial didn't show a statistically significant overall survival benefit, but there was a strong trend favoring the chemoradiation arm. So the implication is, especially for these more advanced T3 or T4 GE junction tumors, adding neoadjuvant radiation significantly boosts local tumor kill. This strongly supports considering a neoadjuvant chemoradiation approach, much like the cross-protocol used for esophageal cancer, as a very valid and often preferred option for these junctional tumors in many centers.
That's a really key point for us. So for a T3 or T4 GE junction tumor, it sounds like there's a real discussion to be had in the tumor board, FLOT versus something like cross-style chemoradiation.
Yeah.
How does that usually play out? Is there a clear preference or does it depend?
That's exactly the discussion. And honestly, both are considered Category 1 options by NCCN for GE junction tumors, which tells you there's legitimate equipoise. A radiation oncologist might lean towards chemoradiation, especially if it looks more esophageal, like a CR2, if it's bulky, or has significant nodal disease. We see the PCR benefit in POET. We know cross works well for esophageal. The local control argument is strong. A medical oncologist might point to the robust overall survival data for FLOT across the broader gastric-GEJ population and its strong systemic effect. The decision often comes down to specifics: the exact epicenter location, the TNN stage, patient fitness, concerns about surgical margins with a bulky tumor. For example, if there's concern about achieving an R0 resection with chemo alone, chemoradiation might be favored to maximize downstaging. If the patient is frail, maybe the toxicity profiles slightly favor one approach over the other. It's truly personalized, multidisciplinary decision-making. Both are excellent options, and sometimes you might even see sequential approaches considered, like starting with FLOT and adding radiation later if the response isn't great.
That makes a lot of sense. It really highlights why those multidisciplinary tumor boards are so critical for these complex cases. Okay, fantastic breakdown of the decision process. Let's shift gears slightly and distill this down into some high-yield clinical pearls. What are the absolute must-remember takeaways from everything we've covered? The things you really need to have locked in.
Okay, clinical pearls. Let's boil it down. Pearl number one. That GE junction classification based on the epicenter's 2-centimeter relationship isn't just academic, it's foundational. It dictates staging, treatment pathways, esophageal versus gastric. You have to get this right first.
Pearl 1. 2-centimeter rule for GE junction is paramount. Got it.
Pearl number two. For gastric cancer aiming for cure, D2 lymphadenectomy at a high-volume center is the NCCN surgical standard. It lowers recurrence and improves survival. And remember, at least 15 nodes examined for accurate staging.
Pearl 2. D2 dissection, high-volume center, minimum 15 nodes. Check.
Pearl number three. Perioperative FLOT is the undisputed gold standard systemic therapy for resectable gastric and GE junction cancer. It replaced ECF based on that remarkable 15-month median overall survival advantage in FLOT4. No FLOT.
Pearl 3. FLOT is the standard perioperative chemo, superior to ECF-Roger.
And maybe a bonus Pearl 4, specifically for radiation oncology folks regarding those GE junction tumors. Remember, POET neoadjuvant chemoradiation is a very strong contender, especially for T3, T4 disease. It boosts PCR rates significantly and should always be part of the multidisciplinary discussion for these junctional cancers. Don't just default to FLOT without considering it.
Pearl 4. Don't forget neoadjuvant chemoradiation, like CROSS or POET inspired, for advanced GE junction tumors. Excellent pearls. Really summarizes the key action points. All right. You ready for a quick board blitz? Let's test our recall with a couple of classic board-style cases. Think through your answer, listeners, and then we'll break it down. Okay, case 1. A 68-year-old man presents with a T3N1 adenocarcinoma located in the gastric antrum. He's medically fit and being considered for curative intent therapy. What is the most appropriate treatment recommendation? Is it A. Surgery with D1 lymphadenectomy followed by adjuvant chemoradiation. B. Perioperative chemotherapy with FLOT followed by gastrectomy with D2 lymphadenectomy. C. Definitive chemoradiation of 50.4 gray. D. Surgery with D2 lymphadenectomy followed by observation. Take a second. What do you think?
All right, the best answer here is B. Let's break it down. This is a T3N1 gastric antrum cancer, clearly gastric, locally advanced, and resectable in a fit patient. Based on FLOT4, the standard is perioperative FLOT. That systemic therapy must be combined with curative surgery, which means a gastrectomy with a D2 dissection. So B covers both the standard systemic therapy and the standard surgical approach. Why not the others? A is wrong because D1 isn't standard, and upfront adjuvant CRT isn't the primary approach here. C, definitive CRT, is for unresectable disease, usually. D is wrong because surgery alone for T3N1 disease has a high recurrence risk. Systemic therapy is needed.
Clear rationale. Ties directly back to FLOT4 and the D2 standard. Okay, ready for case 2. A 59-year-old woman is diagnosed with a T3N1 adenocarcinoma of the gastric cardia. Imaging shows the tumor epicenter is 1.5 centimeters distal to the anatomical GE junction. She is a surgical candidate. Which statement is most accurate regarding her management? A. The tumor should be staged as a gastric cancer, and perioperative FLOT is the only appropriate neoadjuvant option. B. The tumor should be staged as an esophageal cancer, and neoadjuvant chemoradiation with the CROSS protocol is a standard option. C. The tumor should be staged as a gastric cancer, and upfront surgery with a D1 dissection is sufficient. D. The tumor should be staged as an esophageal cancer, and definitive chemoradiation is preferred over surgery. Think about that epicenter location.
Okay, this one hinges on that first critical branch point. The epicenter is 1.5 centimeters distal to the GE junction. That's within the 2-centimeter rule. Therefore, according to AJCC 8th edition, this serous type 2 tumor is staged and managed as an esophageal cancer. So the most accurate statement is B. For resectable T3N1 esophageal cancer, neoadjuvant chemoradiation, often used in the CROSS protocol, is a well-established standard of care option with proven benefits. POET also supports a radiation approach here. A is wrong because it misclassifies it as gastric and limits options. C is wrong on classification and surgical extent. D1 is wrong. D is wrong because she's a surgical candidate, so neoadjuvant therapy followed by surgery is generally preferred over definitive CRT for resectable esophageal cancer.
Perfect. Really drives home how crucial that initial classification is. Okay, one more. Testing some nodal anatomy knowledge. Case 3. Which of these lymph node basins is included in a D1 dissection for gastric cancer, but would typically be considered part of a D2 dissection if the primary were esophageal? A, infrapyloric, B, celiac, C, common hepatic, D, para-aortic.
A tricky one. This tests the subtle differences in nodal station definitions between primaries. The answer is A, infrapyloric. For a gastric cancer, especially one involving the antrum or pylorus, the infrapyloric nodes are right there, considered perigastric, part of a D1 dissection. However, for a primary esophageal cancer, the infrapyloric nodes are further down the GI tract. While potentially involved in advanced disease, they aren't typically included in a standard regional D1 equivalent esophageal dissection or initial radiation field. They'd be considered more extended regional disease, akin to a D2 level involvement if found positive. The celiac and common hepatic nodes, B and C, are D2 for gastric cancer, but they're also common targets for distal esophageal cancer treatment, either surgery or radiation, so they don't fit the question's criteria as cleanly. Para-aortic nodes, D, are generally considered distant mets, M1 for both.
Excellent explanation. Requires knowing that specific nodal anatomy for both sites. Great board blitz. While we have covered a tremendous amount of ground today, it's been a really comprehensive journey through gastric cancer management. Just to quickly recap the absolute core messages for everyone, we stressed how vital that initial classification is for GE junction tumors. Using the 2-centimeter rule, it truly directs the whole treatment plan. We established the D2 lymphadenectomy as the surgical standard for cure, ideally at high-volume centers. We talked about the MAGIC trial being the conceptual leap for perioperative chemo, and then how FLOT4 definitively set the superior FLOT regimen as the current gold standard with that major survival benefit. And importantly, we highlighted the unique considerations for GE junction tumors, where neoadjuvant chemoradiation supported by trials like POET remains a very important and often used option.
Absolutely. And as you've really seen today, managing gastric cancer is incredibly dynamic. It keeps evolving. While we focused on the cornerstones of surgery and systemic therapy today, maybe a final thought for you to consider is how things will continue to change. Think about the growing role of targeted therapies based on molecular markers like HER2 testing and treatment, or maybe PD-L1 status influencing immunotherapy choices. How will those integrate further into the perioperative setting? And even for us in radiation oncology, how might our role adapt? Will we see more personalized radiation fields based on risk, maybe novel uses of radiation for limited metastatic disease, or potentially even de-escalation strategies in patients with excellent responses to FLOT or chemoradiation? The field never stands still, and your understanding of these foundations is key to navigating and even contributing to those future advancements.
That's a great point. The learning definitely doesn't stop here. Keep digging deeper, keep asking those questions in tumor board, and keep refining how you approach these complex cases.
And don't forget to complete practice oral boards at radoncSmartLearn.com and subscribe to Rad Onc Smart Review for our next session. Thanks so much for tuning in.